Comprehensive overview of maxillofacial innervation. This field examines the complex neural structures that innervate the face and jaw regions. These structures form an intricate network that serves both sensory and motor functions. Understanding maxillofacial innervation is crucial for clinical practice. It forms the foundation for effective pain management, precise anesthetic administration, surgical planning, and the diagnosis of various neuropathies. Central to maxillofacial innervation is the trigeminal nerve, also known as the fifth cranial nerve. It provides the primary sensory innervation to the face through its three major branches. These branches include the ophthalmic, maxillary, and mandibular divisions, each serving different regions of the face and providing distinct functions. Maxillofacial innervation encompasses both sensory and motor functions. The sensory components transmit information about touch, pain, temperature, and proprioception, while motor components control the muscles of mastication and facial expression. Understanding the specific distribution of these sensory and motor pathways is essential for diagnosing neurological conditions and planning surgical interventions. Detailed knowledge of maxillofacial innervation is particularly important for surgical procedures. An understanding of nerve pathways guides the surgeon in avoiding damage to critical structures, resulting in better outcomes and fewer complications. In summary, a thorough understanding of maxillofacial innervation provides the foundation for many clinical and surgical procedures in dentistry and maxillofacial surgery. This knowledge is essential for effective pain management and surgical interventions in the maxillofacial area. The trigeminal nerve, designated as cranial nerve 5, is the largest of the cranial nerves and serves as the primary sensory nerve for the face. The trigeminal nerve originates from the lateral aspect of the pons, a part of the brainstem. It contains both sensory and motor nuclei, with its sensory root being the largest of all cranial nerves. The motor root, which is smaller, primarily innervates the muscles involved in chewing. After emerging from the brainstem, the sensory fibers pass through the trigeminal ganglion, also known as the semilunar ganglion. This ganglion is located in a depression called Meckel's cave on the petrous portion of the temporal bone. It contains the cell bodies of sensory neurons and is the point where the nerve divides into its three major branches. The trigeminal nerve divides into three major branches: the ophthalmic, maxillary, and mandibular nerves. The ophthalmic branch, V1, provides sensory innervation to the forehead, eyes, and upper nose. The maxillary branch, V2, supplies sensation to the midface, including the maxilla and upper teeth. The mandibular branch, V3, innervates the lower face and mandible and also contains motor fibers. The trigeminal nerve has a mixed nature. It primarily functions as a sensory nerve, carrying general sensations including pain, temperature, and touch from the face. Its motor component, which is found only in the mandibular branch, innervates the muscles of mastication. These include the temporalis, masseter, and medial and lateral pterygoid muscles. It also supplies the tensor tympani and tensor veli palatini muscles. The mandibular branch, also known as V3, is the largest division of the trigeminal nerve. It is unique among the trigeminal branches as it contains both sensory and motor fibers. The mandibular nerve originates from the trigeminal ganglion and follows a specific course. It passes through the foramen ovale to enter the infratemporal fossa, where it divides into numerous branches. Let's explore the main branches of the mandibular nerve. The mandibular nerve has several important branches. The main ones include the inferior alveolar nerve, the lingual nerve, the buccal nerve, and the auriculotemporal nerve. The inferior alveolar nerve is a major branch that enters the mandibular foramen. It supplies sensation to all mandibular teeth on its side, as well as the lower lip, via its mental branch. It also gives off the mylohyoid branch for the mylohyoid muscle. As we can see here, the inferior alveolar nerve travels through the mandibular canal, giving off dental branches to each tooth root. It eventually emerges as the mental nerve through the mental foramen to supply the skin of the chin and lower lip. The lingual nerve runs in the floor of the oral cavity, just beneath the oral mucosa. It's joined by the chorda tympani branch of the facial nerve, which provides taste sensation. The lingual nerve supplies general sensation to the anterior two-thirds of the tongue, as well as the floor of the mouth and lingual gingiva. We can see the relationship between the lingual nerve and the inferior alveolar nerve, both major branches of the mandibular division. The buccal nerve passes between the two heads of the lateral pterygoid muscle. It's a sensory branch that supplies the buccal mucosa and the skin over the anterior part of the buccinator muscle. Unlike some other mandibular branches, it has no motor function. This diagram shows how the buccal nerve passes between the two heads of the lateral pterygoid muscle. The lateral pterygoid muscle serves as an important landmark for several branches of the mandibular nerve. The mandibular nerve also provides motor innervation through several branches. The masseteric nerve supplies the masseter muscle, the deep temporal nerves supply the temporalis muscle, and the pterygoid nerves supply the pterygoid muscles. Together, they innervate the muscles of mastication. All these branches, both sensory and motor, originate from the mandibular division of the trigeminal nerve, making it the most complex of the three divisions. To summarize, the mandibular nerve is the largest division of the trigeminal nerve and contains both sensory and motor fibers. It exits the skull through the foramen ovale and provides sensory innervation to the mandibular teeth, lower lip, anterior two-thirds of the tongue, and buccal mucosa. It also provides motor innervation to the muscles of mastication. The trigeminal nerve provides sensory innervation to the face through its three major branches. The face is divided into three distinct sensory territories corresponding to the three branches of the trigeminal nerve. The ophthalmic branch, or V1, supplies the upper face from the top of the head to approximately the level of the eyes. The maxillary branch, or V2, innervates the midface region, including the maxilla, upper lip, lateral nose, and lower eyelid. The mandibular branch, or V3, supplies the lower face, including the mandible, lower lip, and anterior two-thirds of the tongue. Here's a more detailed view of how the trigeminal nerve branches distribute across the face. Each zone has clear boundaries that are important for clinical diagnosis. The trigeminal nerve branches exit the skull through specific foramina, which serve as important landmarks for nerve block anesthesia. The supraorbital foramen allows passage of the supraorbital nerve, a branch of V1. The infraorbital foramen is the exit point for the infraorbital nerve from V2, and the mental foramen serves as the exit for the mental nerve, a branch of V3. Understanding the sensory mapping of the face has several important clinical applications. First, it helps in diagnosing trigeminal neuralgia and other nerve injuries by pinpointing which branch is affected based on the location of symptoms. Second, accurate knowledge of nerve territories is essential for planning regional anesthesia procedures for dental and maxillofacial surgeries. Third, it helps clinicians understand patterns of referred pain in the facial region, which can be complex due to overlapping innervation. Finally, it enables precise identification of sensory deficits during neurological examinations, helping to localize lesions affecting the trigeminal system. Principles of nerve block anesthesia. Nerve block anesthesia works by interrupting nerve signals before they reach the central nervous system. This diagram shows the neural pathway of pain signals from a stimulus in the hand to various regions of the brain. Nerve blocks effectively interrupt these signals at their peripheral origins. Successful nerve blocks depend on proper injection techniques. Different injection techniques require specific needle angles and depths, as shown here. For nerve blocks, we must identify the correct tissue layer to effectively reach the target nerve. Recognizing anatomical landmarks is crucial for successful nerve blocks. For spinal and epidural blocks, vertebral landmarks help identify the correct level for injection. Palpable structures like the iliac crest and scapula provide important reference points. The appropriate volume of anesthetic is crucial for effective blocks without systemic toxicity. The volume of anesthetic needed varies by target. Small peripheral nerves may require only 1 to 5 milliliters, while larger plexus blocks might need 15 to 30 milliliters. Patient factors like age and weight must be considered to avoid toxicity. Understanding nerve distribution allows for strategic block placement. This image shows the cutaneous nerve distribution in the arm. By understanding these patterns, clinicians can select the optimal block location. For example, a brachial plexus block at different levels can produce varying areas of anesthesia. Nerve blocks must be understood in the context of the entire nervous system. Nerve blocks may affect both sensory and motor functions. Clinicians must consider both somatic and autonomic nervous system components, as well as the potential for anesthetic to spread beyond the target area. To summarize, effective nerve block anesthesia requires precise anatomical knowledge, proper needle positioning, appropriate anesthetic volume, recognition of anatomical landmarks, and an understanding of nerve pathways to strategically block pain signals. Maxillary nerve blocks are essential techniques used in dental and maxillofacial procedures. These blocks target the second division of the trigeminal nerve, providing anesthesia to the maxillary teeth, palate, and midface region. The greater palatine nerve block targets the nerve as it exits the greater palatine foramen. This foramen is located distal to the palatal aspect of the second molar. For proper technique, insert the needle at a 90-degree angle from the opposite side. Advance the needle 1 to 1.5 centimeters along the greater palatine canal. This block anesthetizes the hard palate and associated palatal tissues. Potential complications include hematoma formation from puncturing the greater palatine vessels, block failure if the needle isn't advanced far enough, and risk of intravascular injection. The infraorbital nerve block targets the nerve at the infraorbital foramen. This foramen is located below the infraorbital rim, in line with the pupil when the patient is looking straight ahead. This block can be performed using either an intraoral or extraoral approach. The needle should be directed superiorly and slightly medially toward the foramen. An infraorbital nerve block provides anesthesia to the lower eyelid, side of the nose, upper lip, and the anterior maxillary teeth from the canine forward. Complications may include hematoma formation from damaging the infraorbital artery, orbital penetration if the needle is directed incorrectly, and paresthesia if the nerve is damaged. The posterior superior alveolar nerve block targets the nerve before it enters the maxilla. The key anatomical landmark is the maxillary tuberosity, located posterior to the maxillary second molar. Insert the needle posteriorly, superiorly, and medially toward the infratemporal surface of the maxilla. The needle should be advanced to a depth of 10 to 25 millimeters. This block anesthetizes the maxillary molars, except for the palatal roots, as well as the associated buccal periodontium. Common complications include hematoma formation from puncturing the pterygoid venous plexus, trismus due to trauma to the pterygoid muscles, and risk of intravascular injection. For all maxillary nerve blocks, remember these key principles. Always aspirate before injection to avoid intravascular administration. Use anatomical landmarks for precise needle placement, and inject slowly to minimize tissue distortion and pain. The parasympathetic component of the autonomic nervous system is crucial for regulating glandular secretions in the maxillofacial region. The parasympathetic system originates from cranial nerve nuclei in the brainstem. Preganglionic fibers travel via cranial nerves to synapse in peripheral ganglia. From there, postganglionic fibers extend to innervate the target glands and muscles. 3 main cranial nerves carry parasympathetic fibers to facial structures. The oculomotor nerve supplies the eye. The facial nerve innervates the lacrimal and submandibular salivary glands. The glossopharyngeal nerve supplies the parotid gland. The pterygopalatine ganglion receives parasympathetic fibers from the facial nerve via the greater petrosal nerve. The ganglion is located in the pterygopalatine fossa and sends postganglionic fibers to the lacrimal gland for tear production, as well as to the nasal and palatal glands. Parasympathetic fibers for the eye travel via the oculomotor nerve to the ciliary ganglion. From there, postganglionic fibers innervate the iris sphincter for pupillary constriction and the ciliary muscle for lens accommodation. These functions are essential for focusing on near objects and responding to bright light. The submandibular ganglion receives parasympathetic input via the chorda tympani nerve, a branch of the facial nerve. The ganglion is located near the submandibular gland and provides parasympathetic innervation to both the submandibular and sublingual salivary glands, stimulating watery salivary secretion. The otic ganglion receives parasympathetic fibers from the glossopharyngeal nerve via the lesser petrosal nerve. Located below the foramen ovale, this ganglion sends postganglionic fibers to the parotid gland, stimulating serous salivary secretion, particularly during meals. In summary, the parasympathetic system to the face involves three main cranial nerves. The oculomotor nerve controls pupillary and ciliary muscle functions via the ciliary ganglion. The facial nerve innervates lacrimal and salivary glands via the pterygopalatine and submandibular ganglia. The glossopharyngeal nerve supplies the parotid gland via the otic ganglion. The parasympathetic system has important clinical implications. Dysfunction can lead to dry eye syndrome due to reduced lacrimal secretion or xerostomia due to reduced salivary flow. Many medications have anticholinergic effects that block these parasympathetic functions. The sympathetic nervous system is a crucial part of the autonomic nervous system that affects the maxillofacial region. The sympathetic system influences three primary functions in the facial region: blood vessel tone, leading to vasoconstriction, reduction in glandular secretion, and pupillary dilation. The sympathetic pathway to facial structures originates from cell bodies in the thoracic spinal cord segments T1 through T4. These fibers synapse in the superior cervical ganglion, then travel along blood vessels to reach facial structures. Sympathetic stimulation causes vasoconstriction in the facial blood vessels. This occurs when norepinephrine is released and activates alpha-1 receptors on vascular smooth muscle, causing contraction of the vessel walls and reducing blood flow. Sympathetic stimulation reduces glandular activity in the maxillofacial region. This includes inhibition of salivary gland secretion, reduced output from lacrimal glands, and decreased mucus production overall. In maxillofacial surgery, the sympathetic system has important clinical applications. Local anesthetics are often combined with epinephrine at a concentration of 1 to 100,000. This stimulates alpha receptors, causing vasoconstriction that reduces bleeding during surgery, improves visualization of the surgical field, and prolongs the anesthetic effect. However, these agents are contraindicated in certain medical conditions. To summarize, sympathetic innervation to the maxillofacial region originates in the thoracic spinal cord and synapses in the superior cervical ganglion. These fibers distribute along blood vessels to facial structures, causing vasoconstriction and reduced glandular secretion. Clinically, these effects are utilized to control hemorrhage during surgical procedures. Salivary glands require precise neural control for proper function. The three major salivary glands include the parotid, submandibular, and sublingual glands. The submandibular gland lies beneath the mandible, while the sublingual gland is located under the tongue. The parotid gland is positioned near the ear and has a distinctive anatomical location. Salivary glands receive dual innervation from both the parasympathetic and sympathetic nervous systems. The parasympathetic system is the primary stimulator of salivary secretion. The facial nerve provides parasympathetic innervation to the submandibular and sublingual glands, while the glossopharyngeal nerve innervates the parotid gland. These parasympathetic fibers synapse in ganglia, then travel with blood vessels to reach the salivary glands, where they stimulate watery secretions during eating. The sympathetic innervation comes from the superior cervical ganglion. These fibers follow blood vessels to reach the salivary glands, where they primarily induce vasoconstriction and stimulate protein-rich viscous secretion. Salivary glands produce two main types of secretions. Serous saliva is watery and protein-rich, while mucus saliva is thicker and contains more carbohydrates. Saliva serves multiple crucial functions in the oral cavity. It lubricates food for easy swallowing, begins carbohydrate digestion with amylase, protects against microbes, neutralizes acids, and helps dissolve food particles for taste sensation. Histologically, salivary glands contain secretory acini that produce saliva, a ductal system that modifies and transports secretions, and myoepithelial cells that help expel saliva when stimulated by nerves. Disruption of salivary gland innervation leads to several clinical conditions. Xerostomia, or dry mouth, can result from medication side effects, Sjögren's syndrome, or radiation therapy. Excessive salivation, called sialorrhea, may occur with certain neurological disorders or medications. Damage to the parasympathetic or sympathetic nerves can significantly affect salivary composition and flow rate, leading to altered taste perception and various oral health issues. The superficial lymphatic system plays a crucial role in immune function and can indicate underlying pathology when affected. Let's examine the facial lymphatic drainage system. Different regions of the face drain into specific groups of lymph nodes. There are several key groups of superficial facial lymph nodes. These include submandibular, submental, preauricular, and cervical nodes. Each node group is strategically positioned to collect lymph from specific regions of the face and head. Lymphatic drainage follows specific patterns. For example, the forehead and scalp drain to the preauricular and mastoid nodes, while the lower face drains to the submandibular nodes. The submental lymph nodes are located in the submental triangle between the anterior bellies of the digastric muscles. They receive lymph from the chin, lower lip, anterior tongue, and floor of the mouth. Understanding lymphatic drainage has important clinical implications. Enlarged lymph nodes may indicate infection or malignancy. Infections spread predictably along lymphatic pathways, and cancers can metastasize through these same routes. In cancer progression, tumor cells can invade lymphatic vessels and travel to regional lymph nodes, forming metastases. This process often follows predictable patterns based on the lymphatic drainage of the primary tumor site. Knowledge of lymphatic pathways is essential for proper diagnosis, staging of disease, and planning appropriate interventions. The internal carotid artery is a key contributor to the blood supply of the maxillofacial region. Arising from the common carotid artery in the neck, the internal carotid artery travels upward to enter the skull through the carotid canal. The primary contribution of the internal carotid artery to the maxillofacial region is through its ophthalmic branch. The ophthalmic artery gives rise to several important facial branches, including the supraorbital and supratrochlear arteries. These arteries emerge through foramina in the orbital rim to supply the forehead and anterior scalp region. A critical feature of facial arterial anatomy is the extensive anastomoses between branches of the internal and external carotid arteries. Specific examples include connections between the supratrochlear artery and the angular artery, the supraorbital artery, and the superficial temporal artery and the dorsal nasal artery with branches of the facial artery. These anastomoses form the basis of collateral circulation, which becomes crucial during vascular compromise. Clinically, these anastomoses provide protective blood supply during arterial occlusion, trauma, or surgical procedures involving major vessels. Venous drainage of the face and jaws follows complex and variable patterns with multiple interconnections. The main venous channels of the face include the facial vein, superficial temporal vein, and retromandibular vein, which ultimately drain into the external and internal jugular veins. The facial vein is a key structure that begins at the medial angle of the eye as the angular vein and courses downward along the face. The pterygoid venous plexus is a complex network of veins located within the infratemporal fossa. The deep facial vein connects this plexus to the facial vein. Note the highlighted danger triangle of the face. This is a critical region due to its venous connections to intracranial structures. The facial veins have a critical connection to the cavernous sinus via the angular vein and ophthalmic veins. This creates a potential pathway for infections to spread from the face to intracranial structures. A closer examination of the orbital region reveals the superior and inferior ophthalmic veins, which connect to both the facial venous system anteriorly and the cavernous sinus posteriorly. The ophthalmic veins serve as a critical connection between facial and intracranial venous systems. This is why infections in this region can be particularly dangerous. This more detailed view shows the angular vein connecting to the superior ophthalmic vein, which then drains into the cavernous sinus. The facial vein also connects to the pterygoid plexus via the deep facial vein. The danger triangle of the face is the region between the bridge of the nose and corners of the mouth. Infections in this area can spread to the cavernous sinus due to the venous connections we've discussed. If infection spreads to the cavernous sinus, it can cause cavernous sinus thrombosis, a potentially life-threatening condition. This is why infections in the danger triangle require urgent treatment with appropriate antibiotics. To summarize, the venous drainage of the face follows complex and interconnected patterns. The critical communication between facial veins and the cavernous sinus creates a pathway for infection spread. The danger triangle region requires special attention when treating facial infections. Pain in the maxillofacial region travels along specific neural pathways that are crucial to understand for effective pain management. The trigeminal nerve serves as the main sensory pathway for the face and is the primary conduit for pain signals from the maxillofacial region. Pain begins with the activation of specialized nerve endings called nociceptors, which respond to tissue damage or potentially harmful stimuli. These nociceptors connect to first-order neurons that transmit the signal to the central nervous system. In the maxillofacial region, pain signals travel primarily through the trigeminal nerve system. First-order neurons have their cell bodies in the trigeminal ganglion. They receive sensory input from receptors in the face and transmit it to the brainstem. Second-order neurons receive input from first-order neurons in the trigeminal nuclei within the brainstem. These neurons cross to the opposite side and ascend to the thalamus. Third-order neurons project from the thalamus to the somatosensory cortex, where pain is consciously perceived and localized. Pain signals can be modulated by descending pathways from the brain. These pathways can inhibit pain transmission at the level of the brainstem and spinal cord. The central nervous system can release neurotransmitters like endorphins and serotonin that inhibit pain signals. This occurs through structures like the periaqueductal gray area and Raphe nuclei. Understanding these pain pathways has important clinical implications for pain management in dental and maxillofacial procedures. By targeting specific components of the pain pathway, clinicians can provide more effective pain control for patients undergoing maxillofacial procedures. Nerve injuries in the maxillofacial region can have significant functional and sensory consequences. Let's examine the classification of nerve injuries according to Seddon's system, which categorizes injuries into three main types. These three types are neuropraxia, axonotmesis, and neurotmesis, each representing increasing severity of nerve damage. Neuropraxia is a temporary conduction block with an intact nerve structure, often resolving within days to weeks. Axonotmesis involves axonal damage while preserving the connective tissue sheaths. Neurotmesis is the most severe, with complete transection of the nerve. Each type of nerve injury has distinct characteristics and different recovery timeframes. Neuropraxia typically shows full recovery within weeks. Axonotmesis has a slower recovery at a rate of about 1 millimeter per day, often taking months. Neurotmesis has poor recovery prospects without surgical intervention. In dentistry, nerve injuries can occur during various procedures. One common cause is wisdom tooth extraction, which can damage the inferior alveolar or lingual nerves. Other common causes include local anesthetic injections, dental implant placement, orthognathic surgery, and in some cases, endodontic treatment. The clinical manifestations of nerve injuries depend on which branch of the trigeminal nerve is affected. Sensory disturbances include paresthesia, which is abnormal sensations like tingling or burning, dysesthesia, which is unpleasant abnormal sensations, hypoesthesia or reduced sensitivity, and anesthesia, the complete loss of sensation. Proper assessment of nerve injuries is crucial for determining prognosis and management strategies. Assessment begins with a thorough clinical examination, including patient history and mapping of affected areas. Sensory testing includes light touch discrimination, pinprick testing, and two-point discrimination. Advanced diagnostics may include electromyography and imaging studies like cone beam CT or MRI. Management of nerve injuries depends on the type and severity of the injury, as well as the time elapsed since injury occurred. Conservative management is appropriate for neuropraxia and some cases of axonotmesis. This includes medications like corticosteroids and antivirals, vitamin B complex supplementation, and low-level laser therapy. Surgical management is indicated for neurotmesis and severe axonotmesis cases. Intervention within 3 to 6 months offers the best results. Options include direct repair, nerve grafts, and techniques like neuroraraphy or tubulization. Several factors affect prognosis, including patient age, with younger patients generally recovering better, time elapsed since injury, type and extent of injury, and the quality of repair if surgical intervention is performed. Advanced imaging techniques have revolutionized our understanding of maxillofacial innervation. These modern technologies provide critical insights into neural structures and their relationships to surrounding tissues. Cone beam computed tomography, or CBCT, provides high-resolution three-dimensional visualization of maxillofacial structures. CBCT is particularly valuable for identifying and mapping nerve pathways like the trigeminal nerve and its branches. This technology enables clinicians to identify anatomical variations and plan nerve block procedures with greater precision. Magnetic resonance imaging provides excellent soft tissue contrast and is ideal for visualizing nerves and their surrounding structures. MRI is particularly useful for detecting abnormalities such as nerve compression, inflammation, or tumors that affect maxillofacial innervation. The absence of radiation makes MRI an excellent choice for repeated scans when monitoring disease progression or treatment response. Ultrasound provides real-time imaging and is increasingly used for guiding nerve block procedures in the maxillofacial region. The clinical applications of advanced imaging in maxillofacial innervation are extensive, leading to improved outcomes and reduced complications. These technologies have significantly improved the precision of nerve block procedures and reduced complication rates in maxillofacial interventions.